Hi, this is hajra, one of the internal medicine residents at St. Vincent Hospital. I would like to thank you for giving me the opportunity to present this very interesting case of neurosarcoidosis presenting as viral meningitis. Neurologic complications of sarcoidosis can affect approximately 5 to 10% of the patients. Common syndromes include cranial mononeuropathy, neuroendocrine dysfunction, a focal or multifocal encephalopathy, aseptic meningitis, and cognitive and behavioral problems. Therefore, the diagnosis of neurosarcoidosis requires very high clinical suspicion. My patient is a 36-year-old previously healthy female who presented with a 3-week history of progressively worsening headache associated with nausea and light sensitivity. She had completed a course of amoxicillin for outpatient diagnosis of sinusitis with no symptomatic relief. Her headaches got worse and were now associated with vomiting and low-grade fever, which prompted her to come to the emergency department. At presentation, she was afebrile with stable vitals, and her physical examination was positive for neck stiffness. Her labs were unrevealing. Because of the concern for secondary causes of headache, she underwent a non-contrast CT that showed no acute intracranial process. She had a lumbar puncture done for the concern of meningitis and was started on empiric coverage. Her CSF was colorless, showed 29 white blood cells, of which 100% were lymphocytes. Glucose was 51 and total protein was 41. This was suggestive of aseptic meningitis. However, her hospital course took a new turn when she developed pendular nystagmus associated with dizziness and ataxia. At this point, the differentials included vasculitis, paraneoplastic syndrome, sarcoidosis, and varicella-zoster virus infection. MRI with and without contrast showed no acute intracranial abnormality. CSF was negative for herpes simplex virus, varicella-zoster virus, and RPR. She was further tested negative for HIV, tuberculosis, and Lyme's disease. ANA, ESR, CRP, and serum angiotensin converting enzymes were normal. A CT chest was done, which revealed bilateral hilar and mediastinal adenopathy as seen on the second image. The differentials at this point were narrowed down to lymphoproliferative disease and sarcoidosis. She underwent cervical mediastinoscopy, which showed non-caseating granulomas, which are consistent with sarcoidosis as shown by the first image. She was started on pulse dose methylprednisone with significant improvement in dizziness and nystagmus. This patient had an uncommon but potentially severe manifestation of sarcoidosis. While the cranial nerves are the most frequently affected, neurosarcoidosis can involve other nervous system tissues. Neurosarcoidosis should be a diagnostic consideration in patients presenting with signs and symptoms suggestive of viral meningitis or pendular nystagmus, although an intercurrent infection or malignancy must be excluded first. Sarcoidosis-associated aseptic meningitis is indistinguishable from other causes of viral infections, including HIV or by tuberculosis or syphilis. Unfortunately, no neurodiagnostic tests are pathognomic for neurosarcoidosis. However, these tests help define the extent of the disease and eliminate other diagnostic considerations. In conclusion, the diagnosis of neurosarcoidosis is often challenging because of several other diseases can mimic clinical manifestations and imaging findings. Chest radiography may be worthwhile in young females presenting with neurological symptoms of unexplained etiology with negative infectious and autoimmune workup. Thank you.